Anybody needs a quick break? This is going to take 4 hours, so you better take a rest. Okay, so I'm going to talk about macular edema, right? I think most of us, some of you also do medical retina, I'm sure, right? So macular edema is one of the most common sight-threatening retinal conditions we deal with. But here we're talking about the context of uveitis, so updates in uveitic macular edema. These are my disclosures. Let's start off with some definitions. I think it's called cystoid, mainly because of these spaces. And now, of course, with OCT, we have a very good appreciation of cystoid macular edema. In the past, we would see this petaloid pattern. Right? Looks like little petals of a flower. And of course, the accumulation, the pooling of dye on fluorescein angiogram was pathognomonic, it's diagnostic of cystoid macular edema. Now, most times we don't even do a baseline fluorescein angiogram unless it is for other reasons. Okay, and we can talk a little bit about when we do angiogram. But because we've got OCT, we are now picking up macular edema much earlier than before. We know that it is due to localized accumulation of fluid, and it's usually in the Henle's layer, and that gives it this characteristic radiating appearance. Right? But once you see this cystic accumulation of fluid, you will actually also appreciate that there are these little tongues, these bridging tissues, and most of them are thought to be sort of mular cells, because mular cells transcend the entire thickness, right, from ILM down to the photoreceptors. So they are likely to represent, at least most of them, intact mular cells. The problem is once they become confluent and the mular cells degenerate and die, then that's the time when you're going to really suffer photoreceptor cell damage, because the mular cells are responsible for normal homeostasis. But macular edema is best understood by the integrity or the disruption of the barriers in the eye. Right? The two main ones in the retina are the inner and the outer retinal barriers. Who can tell me what constitutes the inner blood retinal barrier? Shout it out. Inner blood retinal barrier. So tight junctions, endothelial cells, right? Endothelial cells of the retinal vasculature. So what about outer? RPE tight junctions on which surface? Apex or base? Answer is here. Near the photoreceptor. So apex, apical, not basolateral. Okay? Small print, MCQ question possibly. Okay? But basically, these two tight junctions control the integrity of fluid kept within the vascular compartment. The RPE, of course, is more for the choroid, right? Basically, you're trying to pump fluid out of the subretinal space and prevent choroidal fluid from entering the subretinal space. So if you consider macular edema, the next time think about what predominant mechanism is causing the macular edema. For example, if we look at retinal vascular disease, right? Typically diabetic retinopathy, diabetic macular edema, RVO, retinal vascular occlusions, parafoveal telangiectasia. Where's the fluid coming from? Inner or outer? Where's the disruption? Inner, right? Retinal vessels. You know that there are two plexuses anyway, right? There's a superficial capillary plexus, there's also an outer or deep retinal plexus. We know this because the OCT angiogram, right? OCTA has really given us that information. In the past, you do a fluorescein, you probably wouldn't appreciate that there was a superficial plexus because that's what you see, but on top of, in fact, below that, there is also a deeper plexus, which is masked, right, once the angiogram starts. So it's very difficult sometimes to tell, is this really superficial capillary plexus or deep retina? It doesn't matter, right? It's still disruption of the inner blood retinal barrier. But for others, okay, so inflammation, what do you think is the disruption? Where is it, inner or outer? Most likely inner rather than outer. Occasionally you do get both. You can have inner and outer, right? Because inflammation can affect RPE, and that can affect the tight junctions RPE. But the majority are inner blood retinal barrier disruptions. And the quintessential classic will be post-cataract surgery. Irvine guess, right? Idiopathic though it may be, but it's largely thought to be inflammatory, right? Retinal degenerations like retinal pigmentosa, photoreceptor dystrophies, is it inner or outer? Now I think it will take 6 hours. Come on, inner, outer? Outer, right? Because what is the first cell that suffers after the photoreceptors is RPE, right? You get RPE dysfunction, RPE atrophy. Okay, so this is more likely to be outer. Drug induced can be both. It can be inner or outer. You heard also from Dr. Su that there are some eye drops, the prostaglandin analogs, they tend to give inner retinal blood barrier disruption. The glitter zones, this is the one that a lot of diabetics are now on, right? The glitter zones, which is to reduce insulin resistance in type 2 diabetics. They cause inner blood retinal barrier obstruction. And then it can be a whole host of the others, right? Sometimes mixed. CNV obviously is outer, choroidal tumors tend to be outer. CSC, central serous chorioretinopathy, is outer blood retinal barrier. So the next time you have a cystic macular edema, think, what is the mechanism? Why? Because your treatment might vary depending on what you think is the predominant. Okay, we'll talk about that in a minute. Macular edema in uveitis is not uncommon. Now, of course, it's absolutely criminal if you have a patient with anterior inflammation, anterior uveitis, and you don't dilate that, right? I think that's very, very important. You have to examine what are the compartments that are inflamed and whether or not there are any consequences to the inflammation. In this case, we are specifically looking for macular edema. It may be asymptomatic, the vision may be good, especially in early stages. And actually, macular edema is not a disease in itself, right? It's just a manifestation of the processes. In this case, we're talking about inflammation, right? Which lead to this accumulation of fluid. Most likely, it is due to cytokines. Leukotrienes, IL-1, IL-2, IL-6, all these are the upregulation of all these inflammatory, pro-inflammatory factors. VEGF in itself may also be upregulated. And it is not necessarily with posterior uveitis. It can be with intermediate, it can be with anterior uveitis, but more commonly, of course, with posterior uveitis. And why are we concerned with macular edema? Acute stage, of course, it affects vision, but in the chronic stage, if you don't treat, they end up with irreversible damage, photoreceptor cell loss, retinal atrophy, epiretinal membrane. Okay? So as I mentioned, there are two main mechanisms for uveitic macular edema. The first, a disruption of the inner blood retinal barriers, hyperpermeability, leaks from the retinal capillaries. And the second may be dysfunction of the RPE. So the RPE is responsible for pumping fluid, correct? Pumping fluid out of the retina and maintaining retinal adhesion, retinal attachment. So any one of these two mechanisms can cause it. We diagnose clinically, OCT is the most common way. Fluorescein angiography. When would I do fluorescein angiography? Number one, when I would like to assess the degree of inflammation affecting the vessels. So if you suspect that there's retinal vasculitis, you will do an FA. Second, if I want to exclude significant ischemia, FFA is still the best way to assess it, especially if you have wide field angiography, right? You can use Optos, you can use the new Spectralis with the additional wide field lens, but it gives you an appreciation of peripheral perfusion. And then finally, if you want to look at disc edema or disc leakage, in certain conditions, the presence or absence of disc leakage may make the difference. For example, if you suspect after cataract surgery that the patient might have pseudophakic cystic macular edema, right? And he's also diabetic. You're not sure whether or not it is diabetic macular edema or whether it's pseudophakic CME. And FA will help you because there is the staining and leakage from the disc, and you don't see this typical microaneurysms which you would expect in diabetic macular edema. In which case, then you make a diagnosis of pseudophakic cystic macular edema. These are some other examples of how fluorescein shows you the accumulation of dye in the retinal space, but also the peripheral changes are equally important, retinal vasculitis and ischemia. These are just facts and figures. I'll give them to you in your notes, so you don't really need to copy these. But it is contributing to significant morbidity. Okay. About 30 to 40% of all uveitis patients develop CME in at least one eye, so that's quite significant. A third to about half. And early and adequate treatment of inflammation is the mainstay. So if you don't treat the inflammation, no point treating the cystoid macular edema. Right? I think a little bit similar in principle with glaucoma. But really, there are some patients who are recalcitrant, so you can treat and treat and treat, but you can't get rid of the macular edema. The chronic type of uveitic CME is still the challenge. In the MUST trial, which is the multi-center uveitis steroid trial, if you have cystoid spaces, visual acuity was worse. So these are sort of a coalescence of fluid, so large cystoid spaces. If it's non-cystoid thickening, more diffuse, 13 letters worse. If you have both cystoid and thickening, it's 19 letters worse. So if you have different patterns of VOCT, you have different prognosis. What about subretinal fluid? I mean, I think we see subretinal fluid as a poor prognostic factor generally because of its proximity with the photoreceptor. So if you have subretinal fluid, it's even worse, right? Let's say you have cystoid spaces, you have diffuse cysts, plus neurosensory detachment. I think that's probably the worst of the lot. And a reduction in the visual field sensitivity. So if you have a reduction in macular edema, so let's say you treat them with whatever agent you have an improvement of at least 11 letters if you can achieve at least 20% reduction, which is our main aim, right? If you recall in diabetic macular edema, with each injection we would like to see a gradual reduction in macular thickness. Right? Our threshold for response is about 20% generally. In chronic CME, the mechanism may be slightly different. So in acute CME, most times it's coming from the retinal papillaries, sometimes from RPE dysfunction. And then in chronic CME, this rumbling inflammation causes all kinds of problems. Severe diffuse damage, so it doesn't repair at all, so it doesn't really have a chance to recover. And then, of course, you end up with a lot of permanent damage, which is bad for vision. If you look at these two arms, then you can also help determine which is the best way to manage the disease. If you think it's RPE dysfunction alone, then of course you really don't need any of these, right? You still want to control the inflammation, which is uveitis, and maybe something like a carbonic anhydrase inhibitor, diamox, acetazolamide, which will help increase RPE pumping action. That will be sufficient. But as I said, in uveitis, most of the mechanism comes from the disruption of the inner blood retinal area. Okay? So it is related to inflammatory mediators as well as vascular endothelial growth factor. So I think you see where this is going. We are now looking at pathogenesis and then trying to find targets so that we can treat it with whatever we have currently. But all these result in macular edema, so you can't really tell just by looking at the macular edema whether it's primarily inflammatory or mainly VEGF driven. So what is the management like? Well, anti-inflammatory, I will talk about it in quite a lot of detail. Because if you can't control inflammation, your cystoid macular edema will keep recurring and it will reach a stage of chronicity and so on. You can use temporarily an increased pump. You can try and pump fluid out. So carbonic anhydrase inhibitors. You can use anti-VEGFs. I'll talk also about biologics. That will be covered in more detail by Professor Kwan. And then surgical, vitrectomy, for example, a release of traction, removing the vitreous as a reservoir for all these inflammatory factors. Okay? And then alternative therapies, just a short word about that. Let's start with drug administration. You know that there's many ways, right, to administer medication. So we have topical, we have periocular injections, intraocular injections, and then the slow release devices. And I've listed some of those that are available. Periocular are very important because they are easy to administer. Of course, the same problems which Dr. Su mentioned is that once you deliver the drug, you can't take it out. Right? It's even harder with one of these. If you put it into the orbital floor, how are you going to take out the triamcinolone? Right? So you have to be sure that you are doing the right thing and that you can control the impact of it, let's say glaucoma, right, or ocular hypertension. Same with the intraocular injections. So let's start with local therapy. I think if it's anterior uveitis, most times you don't need systemic therapy, right? You'll be treating topically. steroids with or without NSAIDs. And then usually the macular edema will also resolve because the macular edema was a direct effect of diffusion of these inflammatory products to the back of the eye. So the topical ones work very well for anterior uveitis, maybe some of the intermediate uveitis. Okay? But the periocular injections are required once the inflammatory focus is behind, vitreous, okay, posterior segment. So if you look at anti-inflammatory drops, I mean, we have Modifiers, we have bromfenac, various sort of NSAIDs, macular as well, ketorolac. In general, the Pefenac, which is Nevenac, doesn't quite achieve enough levels at the level of the retina. It can penetrate the eye, but not to the level of the retina. Bromfenac has been shown to reach adequate levels, but we don't really use bromfenac here. Anyone has bromfenac in your countries? It's available in the US, but I don't know of anyone who has used bromfenac here. I certainly have not. And a study by Foster showed that if you have bromfenac alone, it's probably not enough. You use it together with something else, so synergistic steroid, intravitreal steroid. So really topical treatment is not a good solution when the source of inflammation is posterior segment rather than anterior segment. Steroids on their own, topical steroids, have no effect on macular edema, and you can use it for treatment if it is anterior uveitis causing macular edema. So let's say you've got a HLA-B27 positive, very intense anterior uveitis with secondary cystoscopic macular edema. Yes, you just treat that locally. I just want to mention Irvine gas because it's sort of in between. It's not really uveitic, and yet it's not purely vascular either. Okay? And we know that it is usually post-surgery. Irvine had first described it after ICCE, intracapsular cataract extraction, and then Don Gas came along and then demonstrated the edema, and that's why his name is there, Irvine gas. Right? But it's not only cataract surgery, you get it after other forms of surgery, including trabeculectomy and retinal detachment surgery. The incidence is not high, so with phaco, it's less than 10% if it's uncomplicated, right? But when you have a posterior capsule rupture, or you have patients who are at risk, for example, they are diabetic patients without any diabetic retinopathy, they are more likely to get pseudophakic CME after surgery, and usually within 4 to 6 weeks post-op. I think you know about the clinical symptoms. I wanted to highlight that the FA sometimes is useful because it tells us if there is disc leakage, it's more likely to be Irvine gas than diabetic macular edema or any other cause of cystoscopic macular edema. Always be sure that you're not dealing with a primary uveitis. The most common scenario is this: a patient presents for cataract, surgeon does not pick up intermediate uveitis, just has been rumbling on and on. They think it's purely cataract, they remove the cataract. Vision very good in the first 2 weeks, and subsequently it goes downhill. Cystoscopic macular edema, and then you see cells. Right? So always try and exclude an underlying uveitis, especially for atypical cases. Let's say young patients, why should they develop cataract out of nowhere? No reason. Sometimes it is actually underlying uveitis. And that uveitis has caused secondary cataract. And then after cataract surgery, because you had not anticipated it, they develop all these complications. So for Irvine gas, my first line is still topical, so I give Prep Forte together with Nevenac. That's what we have. Ocular is pretty good too, ketorolac, for about 4 to 6 weeks. Usually it resolves completely, and visual acuity goes back to normal. So it's quite a satisfying way to treat. Very rarely do we have to go on to the second or the third line. So this is just to get Irvine gas out of the way. If you combine the two, prednisolone and ketorolac, for example, there's a higher rate of two-line improvement, 90% compared to 67 and 50 alone. Okay? So I usually use both. Do you need oral medication? Usually not. Right? Just topical medication is enough. What about for typical uveitic CME? Right? When do I use local therapy and when do I use systemic therapy? If it is unilateral disease, I try and use local therapy because the systemic side effects of some of this medication may not be worthwhile. If there is no indication from the uveitis point of view. Let's say the patient is fairly quiet in terms of uveitis, and you don't need to start systemic therapy, then go with local therapy, because that is the eye which has the problem, the cystic macular edema. Occasionally, you have bilateral purely ocular disease, or where systemic therapy is not tolerated. That means you give one after another, let's say. Okay, bilateral disease. So you can give local therapy, injections, one after another. So I like orbital floor injections. Has anyone used orbital floor triamcinolone? Okay, so those of us who train in UK probably will be quite familiar with it. It's not commonly used somehow. I think the US, they tend to describe subtenons rather than orbital floor, but I find orbital floor much easier and less traumatic to the eye. So all these are lumped together. This is latest paper, 126 patients, periocular triamcinolone, which includes anything from peribulbar, orbital floor, and subtenoids, okay? 126 patients, 156 eyes, more than 50% resolve CME at 1 month, 57% at 3 months following a single injection. So when we inject, we give 1 cc, which is 40 milligrams of triamcinolone or canolone, okay? 1 cc. And so it's a small volume. You can add a little bit of lidocaine, local anesthesia, but you try not to give too big a volume. Otherwise, you get a lot of diffusion forward, you get chemosis in the subconjunctival space. Right? So I try and keep it under 2 cc in total, maybe a lidocaine of 0.5 or something. Total volume 1.5. 1 additional injection in 21 eyes, 2 additional injections. So it does not mean that you have cured the problem. All you've done is to reduce inflammatory stimulus for the cystic macular edema. You have to be prepared for recurrent or frequent repeat treatment. And even then, 15% failed corticosteroid therapy, and it recurred in 53%. So the recurrency is really very high, and the median time is 20 weeks. In other words, if I give a periocular triamcinolone, which is already in itself like a suspension, and therefore slower release, it's not going to last forever. It will last at least between 3 to 4 months in general, right? If it lasts 6 months, you're lucky. So the median time, about 5 months. This is orbital floor, through the septum, along the edge, so you're feeling, it's almost like a peribulbar which you give for cataract operations. Yeah? Be careful not to go either towards the globe, especially high myopes, you can have ocular perforation, that has been reported. And I even had a patient who came in with a periosteal osteomyelitis. So it jabbed through the periosteum. That's quite scary, right? Always feel, make sure that you're not pushing too hard against resistance. And as you inject, ask the patient to report any pain. If there's any pain, stop. Withdraw needle, check. Because you don't know what compartment you are in. The more vertical, that means perpendicular to the skin surface, the better, right? If you were to angle it towards the globe or away from the globe, you're likely to either hit the eyeball or you might go into the periosteum. So keep it vertical as much as possible. Eye looking up, so it stretches, you move away, the eyeball away from the needle. And once you are in, I use a 1 inch, maximum 1 1/3 inch, 23 gauge. I found that with the 25 gauge, it tends to clog the needle with triamcinolone. And then you tend to have to push. And the more resistance there is, you push harder, you really don't know where you are forcing the drug. So 21 is too big. So 23, the blue needle, for me is ideal. And you don't want it too long, right? Because what you want is actually to put it into the orbital fat. You're not injecting it into the cone, you don't need it like a retrobulbar. Right? So you don't need to go all the way in. The orange needles tend to be a bit longer, 1.5 inch. So you don't want too long a needle to prevent perforation. So if you compare intravitreal and orbital floor, which one is better? Well, I think it is quite logical, right? You're going to get much higher concentrations immediately when an intravitreal injection is placed. But what happens when you have so much steroid in the intravitreal compartment is that pressure is a problem and cataract is more of a problem. So it's a balance. Which one do you want? Do you want greater effect in terms of inflammation control, resolution of cystic macular edema, and prepared to sacrifice a slightly increased risk of cataract progression, and raised intraocular pressure, right? So when you give IVTA, almost all of them will have reduction of suspect macular edema. Of course, reduction does not mean complete resolution. And when you give orbital floor, 20% at a reduced CME. So you might have to give it again, right, for resolution. So obviously, there is a big efficacy difference between the orbital floor and the intravitreal. But with the intravitreal, you have a much higher incidence of cataract as well as raised intraocular pressure. If you look at all the studies and you do better analysis, in terms of intraocular pressure, it's about 40% will have significantly raised intraocular pressure, requiring drops and sometimes even surgery. Cataract progression in triamcinolone is about 50%. So you start out with a bit of cataract, it will get worse. So the best candidates will be pseudophakic patients. Intraocular injections, of course, you bypass all the barriers. We're bringing the drug to where it's needed most, right, in posterior segment, and high concentrations as well. But again, short-lived effect, even with triamcinolone, right? You know that when you push in triamcinolone, it sinks to the bottom as a suspension, and then you get these floaters and so on. Even then, triamcinolone doesn't last more than 6 months. By 3 months, 4 months, the effect of intravitreal triamcinolone wanes, and you still need repeated injections. Is that safe? Every time you give, of course, there are potential complications. What about the different types of steroid? Triamcinolone is hydrophobic, so it stays longer in the eye. Dexamethasone is very, very fast-acting, but short-lived. Right? In rabbits, 3 hours. In humans, it's estimated about 2 hours. So you're not getting a huge benefit if you want it for an anti-inflammatory purpose. I use dexamethasone sometimes in the context of, let's say, PDT combination with an anti-VEGF. So not related to uveitis, because I want a very short-acting anti-inflammatory effect. The other reason I use dexamethasone in combination with anti-VEGF is I would like to challenge and look for a steroid response, because I might have to escalate. Let's say I start off with anti-VEGF, Lucentis, Eylea, but I might have to move on to a second line, which is steroid. Then I would like to know what is the effect in the short term of a steroid challenge. So triamcinolone is 4 milligram because it's 0.1 cc. And if the inflammation is not severe, you could actually start with half that dose, 0.05 cc, very safe, 2 milligram dose. All right? So actually, you don't always have to start off with 4. Half-life of 18 days. In vitrectomized eyes is 3 days. So it does make sense that if you've got a post-vitrectomized eye, whatever you put into the vitreous is going to disappear much faster. Despite what people say, I mean, if you look at the literature on anti-VEGF, for example, they claim, many papers claim, that there is no difference between vitrectomized and non-vitrectomized. Yes, in terms of efficacy and durability, maybe not, because you're supersaturating the receptors anyway. But the actual concentration in the vitreous will be much lower in the vitrectomized eye. Okay? And that's also a consideration, because if you're going to have a vitrectomized eye requiring treatment, maybe anti-VEGF will not be a good idea, because you're having to give the patient every 3 to 4 weekly injections, compared to, say, a longer-acting steroid or an implant. Detectable level about 3 months after a single 4 milligram injection. If you consider the different types of triamcinolone, there is preserved, benzyl alcohol, and non-preserved, right? Triacenes, we have that in Singapore. I'm not sure whether your countries you have the preserved-free triamcinolone. Why is that so? Mainly because benzyl alcohol has been of a great concern to many of us. In the days when we did not have anti-VEGF treatment, our mainstay of treatment for a lot of macular diseases, macular edema, in DME and so on, was triamcinolone. And the problem was the inconsistent response to triamcinolone. Besides cataract and intraocular pressure, it was pseudo-endophthalmitis and sterile endophthalmitis, which we always suspected was from the benzyl alcohol leak. Okay? So that's why it was proposed that we should have a preservative-free triamcinolone. We found that the median intravitreal triamcinolone concentration was higher in the preserved at 7 days only, and after that it was the same. Okay, so the preserved could hold its concentration for a bit longer in the eye. Right? So that means the preservative-free would disappear faster, and there was no evidence of toxic effect in either group. So it didn't really prove one way or the other that preservative-free was superior. Of course, if you have a choice, you use preservative-free, but I think it's much more expensive than the preserve. I don't have preserve-free. Anyone use preserve-free triamcinolone now? Triessence? Okay, all right. So you use that for triamcinolone intravitreal. Okay, very good. Thank you. We now know that, of course, it's a good option because you've got inflammation, so you need a steroid, and you've got cystoid macular edema. Right? So you kill two birds with one stone. This is just one study. There are many studies that show the efficacy of intravitreal triamcinolone. So now we are moving into intraocular territory. We started with topical. We had periocular, like orbital floor, and now we're moving into intravitreal. This is a very, very rapid response. Within 1 week, sometimes within a few days, there'll be improvement in both inflammation as well as cystoid macular edema. So very, very good idea. This is an example of a patient with quiescent uveitis, had cystoid macular edema, which was persistent and would resolve with intravitreal triamcinolone. Right? So before we had anti-VEGF, this was probably the most popular intravitreal preparation. I mentioned endophthalmitis, sterile endophthalmitis. I just want to mention pseudo endophthalmitis. It's thought to be movement of these crystalline particles with the alcohol into the anterior segment. So it causes a wipeout. Corneal edema, severe inflammatory reaction in the anterior chamber, usually without a hypopia. The visual acuity can drop, the hand movements, perception of light, and yet the eye is not painful and not injected. So I had a series of 3 patients, each one consecutive, from different batches of triamcinolone, different vials of course, and all of them had very severe reaction from 660 to hand movement within 24, 48 hours of injection, which is quite scary. Most of them will end up with a tap anyway, right? Because we still have to exclude infective endophthalmitis. None of them grew anything. And the patient with hand movements took 6 months for the opacities to clear. Can you imagine? He was treated for central retinal vein occlusion. At the time, we didn't have anti-VEGF. And after that, he was totally spooked. The good thing was, his macular edema actually resolved. Despite him having, such severe vitreous, he refused to go for vitrectomy. But his macular edema actually resolved. So it's not a problem of the steroid. I think it's a hypersensitivity of some kind to the preservative. You know about ocular hypertension, glaucoma, cataract, vitreous hemorrhage, retinal detachment. I think it's also a bit of technique related. Retinal detachment can occur, of course, with repeated injections, inducing of posterior vitreous detachment. But your technique is very important. Make sure that you measure it out all the time. You know it's a pars plana injection. So the differences here, orbital floor, short duration, IOP rise, risk of globe perforation, lower dose entering the eye, and the success is less than IVTA in terms of reduction of cystoid macular edema. Okay? So it depends on how quickly you want to achieve resolution. If you're really in a hurry, then intravitreal triamcinolone, but higher risk. So with the pathophysiology, we're looking really at other mechanisms of action, such as vascular endothelial growth factor. Surprisingly, VEGF can be upregulated in quite a lot of cases of uveitis, even experimental uveitis. In EAU, VEGF expression was markedly increased. So VEGF is not just for retinal vascular disease, it can be found as one of the promoters of cystoid macular edema in inflammatory conditions. Okay? And that's why people started to use anti-VEGF agents. Interestingly, vitreous levels are similar to those found in wet AMD, but lower than diabetic retinopathy and diabetic macular edema. So there is some biologic rationale for using anti-VEGF agents. Most have been off-label, right? So most people will use Avastin or bevacizumab. I tend to use Lucentis, smaller molecule, no FC portion, hopefully less antigenic. That's just theoretical. Eylea, which is aflibercept, is a slightly bigger molecule. I think it can be used equally well. I don't see a big difference in terms of post-injection inflammation. When ranibizumab was first used, there were concerns about inducing uveitis, right? Because it's a protein after all, or it's part of a protein. But we haven't seen that with the new formulations. In the old days, maybe the formulations had maybe more particulate matter, I'm not sure. But subsequently, I've not had a problem. If you do your anti-VEGF injections, let's say for DME or AMD, and you see them the next day, they're quiet. The eyes are very quiet. Variable results after one injection. Effects obviously are transient. So the effect is going to be more short-lived than intraocular steroid. Right? Triamcinolone will last longer. This is just one paper describing it. Ranibizumab for refractory uveitis-related macular edema. The conclusions here were that it could increase visual acuity, resolve cystoid macular edema in patients who are refractory or intolerant to standard in corticosteroid. So this is a good option to use when you are worried about the side effects. Young patients without cataract, you don't want a cataract to form, right? So I would use it in that context. Patients who have pre-existing glaucoma, and you don't want to aggravate a glaucoma, and you don't know how well you can control intraocular pressure after triamcinolone, I would start off with an anti-VEGF. Unfortunately, the evidence is still very weak. We don't have level 1 randomized controlled trials. So the aim is really to try and control inflammation. I'm not telling you that anti-VEGF is the mainstay or first-line treatment for uveitic cystoid macular edema. We consider anti-VEGF therapy on a case-by-case basis. Usually we prefer the uveitis to be inactive, obviously, right? And in cases where triamcinolone is contraindicated, as I mentioned earlier. Sometimes you can use a combination, so adjunctive treatment. Let's say the patient is controlled with oral medication, let's say oral prednisolone. Uveitis is under control, right? And you want to treat just the cystoid macular edema in a quiet eye, then maybe anti-VEGF is a good possible way. But really, we're trying to look for longer duration of action, trying to reduce frequency of injections, okay? And that's where, of course, delivery systems come in. You know, of the most common delivery systems that we have will be something like the Orbital palette, the DEX implant. We now have Reticert and Illuvian, right? So all these basically try to achieve the highest possible level of the drug in the vitreous, and hopefully with minimal side effects. So let's look at corticosteroid slow-release devices. I think the most common one is DEX. Who has DEX in your country? Dexamethasone implants? India, certainly. Yeah, Indonesia, good. Taiwan. So most countries now, I think, starting to have Orbital or DEX implant. Illuvian, anybody? We don't have it in Singapore. Malaysia? Anybody? Illuvian? Reticert? Anita, do you know whether Reticert and Illuvian are approved in Singapore? Yeah. If I'm not mistaken, they never even put up for approval. Yeah. I think only the trial, but not for approval. So, yeah. Yeah, and it's also very expensive, right? Very expensive. Yeah, so it's really hugely expensive. So I think that's the main reason why it's never been brought in. But okay, I will talk mainly about Orbidex. Ivation Thermotics basically died because after the phase 1, they never went on to a phase 2 in DME. They were looking at diabetic macular edema. This is a biodegradable, looks like a little screw, right? And then it slowly dissolves. It's quite interesting. It's a degradable polymer. So actually, it's a good concept. And phase 1 was positive, but for some reason, they never went on to phase 2. So let's take this out of the equation for now. Firstly, the Orbidex implants. The study that, the pivotal study for Orbidex, which is approved now for uveitis in many countries, is the Huron study, which is chronic uveitis evaluation of the intravitreal dexamethasone implant. Do you know that most companies, a big pharma, have one department just to think about names for trials? It's very complex, right? I mean, trying to find an acronym for this. Anyway, the Huron study. Simple design: sham versus lower dose, 350 microgram versus 700 microgram. Just to cut the long story short, 350 is now thought to be less effective and therefore stopped. 700 microgram is the standard dose of DEX implant for all indications, for uveitis as well as for RVO and for diabetic macular edema. Okay? So in uveitis, of course, the endpoints are different from DME. Right? Here you're looking at vitreous haze because all these patients had non-infectious posterior uveitis. I emphasize non-infectious because you are giving an you're giving a steroid or any kind of immunosuppressive therapy in the eye. You have to be absolutely sure that you're not dealing with an infected agent. There have been reports of cytomegalovirus, retinitis getting worse, TB, vasculitis getting worse after steroid without anti-infectives. So be very sure, okay? You don't put this into the eye until you have done due diligence to exclude an infective cause. I think that will be emphasized over the next few days, especially for posterior uveitis. Okay? So let's say you have excluded, these are all non-infectious posterior uveitis. So the first was, when you put in the implant, what happens to the vitreous haze? And we want the vitreous score to be 0, right? You want it to be quiet. So by study week 12, it goes up to a peak of about 47% with the DEX. The sham is only 13%, 12, 13%, statistically significant. So as far as inflammation in the vitreous is concerned, very effective, right? You put in a DEX implant, vitreous will quieten down, and up to the study week, which is here, which is 18-week mask extension. So this is 18 weeks. 31% of patients were still quiet. Unfortunately, the DEX implant did not last 6 months. The original design was for it to be re-implanted every 6 months. But really, in all trials, at 3-4 months, whatever you are treating came back. Macular edema came back, Vitreitis came back. So you cannot tell patients this implant is going to last 6 months. And so they've had to change the label somewhat in many countries, 3 to 4 months. This is just for those of you who don't know the scale. This is the sun scale. Clear to 4+. What grade do you think this is? Between probably 2 and 3, but certainly optic nerve is just visible and blurred. You can still see some vessels, so between 2 to 3. Okay. Now, if you look at the DEX implant versus the sham, the time required to achieve vitreous haze 0 is also much shorter. So 80% of patients versus only 20% of patients could achieve 0 haze within 2 months, so less than 60 days, which is what you want, right? I mean, you want to control the underlying inflammation. So in that sense, Orbital, the DEX implant, is quite effective for control of intraocular inflammation, especially if it's unilateral. And so you therefore also expect better effect in terms of visual acuity. In this case, visual acuity gain of at least 15 letters, quite high, over 40% improved by at least 3 lines. What about macular edema? Again, the DEX implant had a greater effect in reducing macular edema than the sham. So I think as expected, whatever steroid you put into the eye will have a beneficial effect on systemic macular edema. Of course, we all worry about intraocular pressure, but it is less than triamcinolone. Historically, we are all scared of glaucoma, right? Especially if you're not a glaucoma specialist. And sometimes the pressure changes can be very prolonged. So even after the effect of triamcinolone has worn off, your ocular hypertensive effect can come later, not consistent. Sometimes it comes at 3 months, sometimes at 6 months, sometimes even later. and it can persist after the steroid effect has waned, right? So triamcinolone used to have that kind of unpredictability to it, and that's what made it quite frightening to use. Dexamethasone, on the other hand, because it's water soluble probably, gets in and out of the eye quite consistently. So within 2 months, it reaches a peak, 60 days. And then by 4 months, there's probably very little drug left in the eye, and the IOP goes back to baseline. And we don't see a cumulative effect, which is quite encouraging. For some drugs, the more injections you give, the more times you give, the higher the peak, the baseline IOP. In this case, no, it tends to fall back to its original. And in the Huron study, you find that actually the rate of patients with significant increase in IOP was 1.4% in DEX implant, 2.8% in the sham, so not significant difference. And the patients with very high IOP, more than 25 millimeter mercury, 4.2 in the sham, 0% in the implant. Why? Because these were uveitic patients, right? So the fact that their pressure went up was because their uveitis was not well controlled. I mean, most people look at this and say, how can that be? I put in a steroid, and yet the pressure was worse in the sham. That's because these were uveitic patients. It's slightly different if you talk about DME, diabetic macular edema, where there is up to about 15%, 16% of more than 10 mm rise of IOP with the DEX implant. Whatever it is, you cannot say no. You can't say never, right? But in this study, small study nonetheless, there was no significant difference between those who had the implant and those who were sham in terms of intraocular pressure, okay? Because there are additional benefits of controlling inflammation more quickly and more resolutely with respect to intraocular pressure. Yes, Houston.
So just to interrupt, but just wondering for Ozurdex, with regards to the IOP issues, what are the contraindications for Ozurdex? So I spoke to some American ophthalmologists. According to him, in America, the only absolute contraindication is the Hughes ratio of more than 0.8. Yep. And they don't, they disregard the presence of pre-existing glaucoma treatment as a contraindication. What do you feel about that?
So there are no absolutes here. So the question is, what are your contraindications, okay, to the use of an Ozurdex implant? I think certainly absolute glaucoma or very severe glaucoma, so let's say as a guideline 0.8, 0.9 cut this ratio, I will be very worried, because are you going to knock them out, knock out the fields when you have fluctuations of IOP? I think if your patient's on maximal therapy and you are not controlling the IOP, I wouldn't put the DEX implant unless I really had no other choice. Yeah? So I still think that there are contraindications to it. On the other hand, if you have a patient who is pseudo-phakic, right? Patient who has had vitrectomized eye before, Ozurdex may well be better than any other agent. Because it's a slow release, you're not giving it as a reservoir. Once you don't have vitreous, the vitreous does not hold the drug anymore. You need a slow eluting type of implant, right? But as for absolute contraindication, I'm still very cautious. I think if you're not sure, you check your glaucoma colleagues. And it's not so much whether it's going to knock out 80%, 90% of patients. It's at 1% or 2% is enough to make a difference. They're already left with such small fields, and you might snuff it out altogether. So I think you have to balance your risk benefit. Okay? But I agree with you, in the US, I think they try not to do it in absolute end-stage glaucoma. So there was about a 17% requirement for IOP lowering medications. Fortunately, we have pretty good medication now. So I don't recall having had, in all these years of using a DEX implant, a patient who needed to go for surgery. All right, most patients just needed that temporary period where you control the IOP. Cataract progression, of course, is a problem. And don't forget, our uveitis patients are phakic, mostly. They tend to be of a younger age group. Right? And you're actually opening a can of worms. Right? You create one problem leading to another. So now you accelerate the cataract, you have to do cataract surgery. Cataract surgery is inflammatory, right? Then they get recurrence of the uveitis and so on and so forth. Okay, so I think one has to consider very carefully in phakic eyes what happens, because this is a very short study, and that's why you're not seeing huge numbers. But on average, it's about 40% in triamcinolone, and about half of that in dexamethasone. You wait long enough and you give them often enough, all of them will at some stage require cataract surgery. How do we know? When we treat one eye and not the other, you see the asymmetry of the cataract. Whatever it is still a steroid. Okay? I just very quickly mentioned Retisert because you might have read it in literature. It's a different steroid, fluocinolone acetate, designed to last, wow, 1,000 days. I don't know, I have no experience with this personally, but I've been looking at the literature. Really sounds interesting. It looks like a pellet like this. It's a tiny one. Drug release is 0.6 micrograms per day, reaches a steady state, and then it drops to 0.3, 0.4 micrograms for up to about 30 months. And it's supposed to have a long-lasting effect. Can I ask Vishali, do you have experience with Retisert? No, I think very few people in Asia really have. Maybe in the US. Yeah. There have been 3 multi-center randomized controlled trials of phase 3, 2 of them double mask and 2 doses and so on. Right? Basically, you still have recurrence, but the rate of recurrence reduced from 54% to 7% after implantation. So this is really for people who have very recurrent and chronic inflammation. You can stabilize or improve visual acuity 80% and reduce the need for systemic corticosteroid. So it's good steroid-sparing option. Unfortunately, we don't have this. This is just to show the time to recurrence is much slower with the Retisert implant because of this long delay. It holds the steroid for a long time. But it always comes with a price, right? So at 3 years, at the implant, you need 30% will need IOP lowering drugs. Standard of care, 8.7% statistically significant. 30% required a filtering operation. So this is not minor increases in pressure. This was a significant increase in pressure and may not be controlled with. So that's the key difference. If you look at this 30%, you tell patient, you may need a filtering operation. That's quite high. That's quite alarming. And of course, cataract, 94%. So I think, having said, having looked at this, which one would you prefer? Something that you insert perhaps can last 1-2 years, much higher cost, of course, with the higher risk of needing surgery for glaucoma and surgery for cataract, versus perhaps having to give 3-4 DEX implant injections, slightly better safety profile. You choose. Illuvian is also fluocinolone. It looks like a little pellet like this, like a pencil nib. And similar to Retisert, also fluocinolone, 180 micrograms. It has its own injector, and you leave it in the pars plana. Slow release, again about the same dose, but more favorable effects on intraocular pressure. It is approved in various European countries, but mainly for chronic DME. There are a few countries that have approved it for uveitis, but most of the Illuvian studies have been on diabetic macular edema, which are chronic. And by chronic, we mean it's been there for at least 18 months. So that's a long time. The most adverse effect is, of course, cataract and pressure. 1/3 of patients associated with increased IOP, and 6%, not so bad, requiring some kind of procedure. And then lastly, we look at the systemic treatments, which are largely targeted at inflammation control, right? But if you treat inflammation, you might also have a beneficial effect on cystoid macular edema. I think other speakers will talk about systemic corticosteroids. I will not dwell on this. Prednisolone 5 milligrams equivalent to this will be in your notes. So you know roughly what you're exposing the patient to. Just to say that when you initiate oral medication, you have to exclude infective causes. You want to hit them hard early and then taper. So the principle is not to give low doses for long periods of time. The longer the suppression of the hypothalamic axis, the worse it is. And when you stop, depending on how long the patient has been on and what dose, you have to taper fairly rapidly, but the last bit, 10 milligrams and less, slow it down a bit. Okay? Because your endogenous level of cortisol is above 10. So you can reduce it to about 10, no problem. But below 10, slow down the tapering. I don't think I need to remind you of all the myriad systemic adverse effects of systemic corticosteroids. There are non-steroidal anti-inflammatories that have been shown to work for macular edema. This is one of them, sirolimus. And it's as a suspension, it's injected. It looks a little bit like triamcinolone. It's an mTOR inhibitor. So it interrupts T cell proliferation, and therefore it reduces IL-2 and other cytokine production. It's not received approval. This is a Sakura study, which is a pivotal study. And you find that in the Sakura study, again, the main outcome was vitreous inflammation. I won't really talk about that. But more importantly, it did not gain FDA approval because when the two studies were integrated, Sakura 1 and Sakura 2, you find that it did not reach statistical significance. So they had to go back to the drawing board, have a new set of studies, because one was positive effect, one was not. Can you see it was Sakura 1 was statistically significant, Sakura 2 was not. So when you have a disagreement between two studies, same design but done in different places, usually FDA will not approve. And so this drug was not approved. But in terms of macular edema, it had a beneficial effect compared to the active control. What do you mean by active control? It was not a pure sham. There was 44 microgram of sirolimus. So there was a little bit of sirolimus in the sham injection as well. Okay? So you can see here the mean CRT reduction was 20%, just over 20%. So maybe it has some promise. It's steroid sparing, and when you want to treat it locally with an intraocular injection. And the good thing was it did not seem to cause increased rates of IOP rise or cataract, unlike steroids. So it's useful for the patients that we talk about where intravitreal steroids may be contraindicated. I won't have time to go through all the immunomodulatory drugs. I just want to highlight a few where its effect on cystoid macular edema has been studied. In CellCET, mycophenolate, in 19 patients, this is a paper from Neri, effective in controlling macular edema, which was unresponsive to standard immunosuppressive therapy, reducing the recurrence rate of uveitis. Interferon has also been used, effective in 15 out of 24 patients, not perfect. Tumor necrosis factor, the three main ones, etanercept, infliximab, adalimumab, but the main ones that might show promise would be infliximab and adalimumab. We do not use etanercept because it's thought to aggravate uveitis. I'm not an expert in immunomodulatory drugs. I think other speakers will talk about this. And then finally, anti-TNF. Okay? Anti-TNF as a whole, 15 eyes treated, 27 eyes conventional treatment. Visual acuity improved only at 3 months, but not at 12 months. So it does not seem to match our intravitreal treatments, either steroid or anti-VEGF. Tocilizumab, which is a humanized antibody against IL-6. This was a study by Adrian. 5 patients receiving this drug, 8 milligram per kilogram at Q4 intervals. And all these patients that failed conventional therapy all showed significant improvement, and in terms of vision as well as anatomy. And then finally, you can also inject some of these drugs intravitreally. I've never tried it. Maybe some of the other speakers might have some experience. Intravitreal methotrexate in this study by Taylor, 12 or 15 eyes completed follow-up. Mean VA and macular thickness improved. No significant adverse effects, so that's one option. Adalimumab, unfortunately, did not show an improvement in macular edema, so we still don't know whether it's safe. We talked about acetazolamide, which is Diamox already. If you suspect there's maybe RPE dysfunction, then I think that's the first line. Somatostatin analog, octreotide, is supposed to help in the inhibition of proliferation of endothelial cells. So it helps to stabilize the inner blood-retinal barrier, somatostatin. And then hyperbaric oxygen, which is used for everything that nothing else can treat, right? Anything from hair growth to pimples to whatever, I don't know, hyperbaric oxygen. Some of you are vitreoretinal surgeons. You might have to use vitrectomy for one of these indications. Remove media opacity most of the time. And sometimes when some control, you want to reduce inflammation, you are trying to reduce the vitreous reservoir of pro-inflammatory factors, and of course, epiretinal membrane. So I've given you a whole sort of picture, right? But let's bring this problem back into context. When you have uveitis, you have to look for complications arising from uveitis, front or back. And in the retinal, of course, we're concerned with macular edema, because macular edema has significant morbidity. If you don't treat it early, you end up with irreversible visual loss. The control of the underlying inflammation should be a priority. Any treatment that can control both inflammation as well as cystoid macular edema, of course, should be the first line, right? So we're thinking, of course, of steroids. But there are many other options. Whether you use it local, which means topical, periocular, or intravitreal steroids, you have to choose based on the scenario, the circumstance. The chronic CMEs, we still don't have a good answer. All right? Whatever you throw at them, some of them will be recalcitrant. So basically, we need more studies with larger sample size, longer follow-ups for uveitic macular edema. My mainstay now is steroids, if not contraindicated, intraocular. I hardly use triamcinolone, so my first line will be an Orbital implant. If there are contraindications, I will use an anti-VEGF agent and then control inflammation systemically, perhaps with corticosteroids or any second line. Thank you. I'll take some questions.
Thank you.
And Paul?
Wonderful talk. Good start. Thanks, Adrian. For post-op CMO, non-responsive to topical, what would be your second line?
My second line is an orbital floor triamcinolone. I don't give triamcinolone intravitreally now because I'm afraid of the complications, but orbital floor triamcinolone seems to work pretty well.
And how long do you wait for?
4 to 6 weeks with a topical eye drop. So I use a combination, NSAID plus Pred Forte. I use Navenec or Macular, and I would say that 90-95% of them will resolve with first line.
And if the orbital floor PA doesn't work, you give a second one at 3 months? Or?
No. So I think if it doesn't work, I will go on to an anti-VEGF. Right? And if anti-VEGF doesn't work, then I'll give an Orbital implant. By then, I think it should work.
Yeah, because the Orbital usually works very well.
Yeah. Yes.
Intravitreal injections, can we decrease the dose to 2 milligram?
Which one?
That IV gave were
Yes, of course.
1 milligram were given. So, do you have any experience on 2 milligram with decreased side effects and maintaining the same efficacy?
I think if there is inflammation, you need 4 milligrams. I think if this eye is quiet and you just want to treat cystoid macular edema, certainly if you're worried about pressure and if the patient is faking, maybe I'll give 2 milligrams. As I said, I use triamcinolone intravitreally almost very sparingly, almost never now, because I have an option of using the DEX implant. But I know in many countries, it's not available or cost is an issue, right? So if you are using triamcinolone, why not start with a lower dose? I don't see any harm in starting with a lower dose, and if you need to, you can escalate to 4 milligrams.
And in case of vitrectomized eye, if you give positive simulation, then what is the longevity kind of?
The same. Yeah. So you find that because it's a slow release, so the presence or absence of vitreous doesn't make a huge difference in terms of longevity or duration. Unlike a reservoir, right? You give a suspension in the vitreous, unless you have done a very poor vitrectomy, you still got so much vitreous and it still acts as a good enough reservoir. But with an implant, which is slow release, it makes sense, right? I mean, you're going to have slow eluting steroid anyway. It depends on how much biodegradable polymer is left. So in a vitrectomized eye, it's the same duration of action with the DEX implant.
Any indication for combined anti-VEGF and steroid?
Generally, I don't like to give combined because I won't know which one is the one working. Right? I would like to exhaust one and then add the other. Okay? For example, if I've given a patient anti-VEGF because I don't want to start him on steroids intraocularly, young patient, you don't want a cataract to form, we give anti-VEGF, we give a course of let's say 3 to 6 injections. And if you're getting the desired effect, then you continue with the anti-VEGF, right? And hopefully, as the disease settles, inflammation is controlled, you don't need to give so frequently. Unlike, let's say, diabetic macular edema, it's not going to be as aggressive. But if you've got significant inflammation with cystoid macular edema, no point giving anti-VEGF again, because you know that the inflammation is the driver of the macular edema. So you give steroid. To give both to me doesn't make a lot of sense unless you've started on steroid and you're not getting a complete response and you want to augment that response with anti-VEGF. The second scenario is where there's neovascularization. I did not talk about neovascularization. You can get secondary choroidal neovascularization or retinal neovascularization because when you treat steroid, you are not inhibiting the ischemic process. Right? So in these cases, you have to watch out for new vessel formation from time to time. So I have a patient who is on Orbital every 4 months, 5 months to control cystic macular edema, his eye is quiet. And then every year or so, he develops new vessels and pre-retinal hemorrhage. And then he needs, interjected between Orbital, he needs an anti-VEGF. Right? So I think anti-VEGF is very powerful, but very good for those with coexistent neovascularization. So I don't think a combination is really necessary. Most times you can use one and you find the best option. And only use the other if you need more effect or when you're not getting the desired effect.
Another question slightly different from the topic. In inflammatory CNPN cases, now anti-VEGF injections are being given. So when we monitor the course of the disease, we do see the SRF as a mode of activity, as a kind of parameter of activity. Do you see anything extra like retinal hemorrhage or anything while monitoring the post-inflammatory CNPN anti-VEGF?
So it depends on the underlying cause of the inflammation, right? If it's a choroiditis, then you may not be able to see much signs in the vitreous, like deep vitreous cells won't be significant. For example, PIC, punctate inner choroidopathy, typically no cells at all, right? But multifocal choroiditis is different, right? When you see vitreous activity, sometimes accompanying the activity of the choroidal neovascularization. So in terms of markers of activity, you still need your OCT. Yeah. Other than that, I would look at hyperrefractive white dots. You know what these white dots are? They are activated microglia, macrophages. And when it's mainly inflammatory, you get more white dots than in a non-inflammatory state. Right? So when you treat and control the inflammation, these white dots decrease significantly or even disappear. Having said that, even in AMD, which is typically not inflammatory, not uveitis, you see white dots. And the white dots decrease after you treat with anti-VEGF. So I think that's just probably a surrogate marker. We are not really looking at inflammatory markers. You know. I sometimes look at the choroidal thickness on enhanced depth imaging, so EDI, but it's not really for decision making. So whatever it is, you still base it on fluid and OCT evidence of choroidal activity, neovascular activity. OCT angiogram is actually very useful because you can have an active CNV without leakage yet. You don't have neurosensory fluid or blood, but you see flow increasing, then you know or you expect that the CNV is going to become more active in the future.
That means OCTA or FFA is mandatory for studying injection in this case.
In the past, I used to do much more FFA and ICGs, but now with OCTA, it gives me an idea of whether or not it's safe to leave the lesion alone. For example, if I treated very effectively, the fluid all dried up, right? Vision is improved. And then I follow these patients for 1 month, 2 months, 3 months, and the OCTA is showing that net, which is OCTA flow, increasing. Despite the vision remaining the same, everything remaining the same, it is imminent that this patient is going to reactivate. So at some point, I might give an anti-VEGF, or if I'm on a treat and extend regimen, I will not extend beyond that limit. Because if you do, you run the risk of the patient having active CNV breakthrough while you're on anti-VEGF. This only applies to anti-VEGF. I mean, I wouldn't say you can use the same thing for steroid, right? Because this is neovascular complications. I think we have to stop.
No, this is first time we are overshooting and I may kind of don't wanted to say that, but yeah, I think great. But I just wanted to ask one question. Because we all treat, and I do see some patients where I do not treat those. What are the macular edema where you will not give any treatment? Like this macula is dead,
Yeah.
and you do not want to give any injections or any kind of treatment.
Okay, so this is a controversial topic, and we face this not only in uveitis but also in any kind of AMD as well, right? When is treatment futile for cystoid macular edema? So we're looking really for cystoid degeneration rather than cystoid macular edema. So number one, you give a trial of whatever treatment you want, but you must give it enough and at an appropriate interval. And you're not getting a response at all. Visual acuity has no improvement, no change. And the OCT thickness has not changed, the configuration of the macula has not changed. Let's say you've given 3 injections of an anti-VEGF and nothing has happened, right? Then usually I will follow with a FFA, fluorescein angiogram. And from there I'll see whether there's significant leakage or not. If it's just pooling, then probably you're not going to get any additional benefit from repeated injections, right? If it is leaking, I will still continue to treat. Maybe I will switch agents. So let's say I started with Lucentis, I will switch to Eylea, and that still doesn't work, I might switch to Orbital, etc. But at some point, let's say you've done all that, first line, second line, you've switched 2 times, 3 times, you've given it enough time to work. Then you watch, you stop treatment for a while. That doesn't mean you give up on the patient, because let's say he's got a baseline of recalcitrant edema, but 3 months later it's worse if you have withheld therapy. Then it's still worthwhile treating because you are maintaining vision. Right? So I always tell patients that we are not giving up on you, we are seeing whether the treatment has any added benefit. And one of the benefits of treatment is to prevent further deterioration and decline of vision. Of course, if there is no visual potential, let's say vision acuity is already hand movement, atomic figures, I ask patients, after the injection, did you feel an improvement? Because they can tell you subjectively, not just VA alone. And that's very important. If the patient says no difference at all, after one, then I think you would believe it. But although it's counting figures, if the patient says, oh, I could see better, and usually it's contrast, right? You can improve contrast, you can find that the fluid has come down, don't give up. Right? For all you know, maybe that would be the better seeing eye if the other eye was involved later on. So I seldom give up so easily. I give at least 3 to 6 months of therapy. First line doesn't work, second line doesn't work, try third line. And then you stop for a while. And if the edema worsens after you stop, then there is some utility in continuing.
Perfect. I think we should thank Adrian for his talk and really enjoyed it.
Thank you.
Now quickly break for a tea probably, and as we have little time left, maybe you can bring the tea inside, and I highly encourage